Hello and welcome back to this Vein and Lymphatic Forum. We are at the DeBakey Cardiovascular Live Studios at Houston Methodist Hospital in Houston, Texas. I am Ulises Baltazar. I am your host, and today's show will have a very special guest that we'll introduce after second half. That is going to talk to us about ultrasound. I'll start discussing some of the basics of ultrasound. I'm not going to go in any depth. I'm not going to go into physics and things that I don't know. I'm just trying to give you an idea and give you my concept, why I think ultrasound is important in regards to venous insufficiency. And why it's so important from my perspective, from my point of view, that the physician that is going to perform a venous procedure, you call it open surgery or venous procedure or venous ablation, should be familiar with ultrasound. And I think the physician himself at some point during the assessment of the patient has to see the patient himself with an ultrasound, because we have vascular labs that report all the numbers that we go by to make our decision if we are going to perform a procedure or not. And then as soon as we are with the patient and ready to go for an endovenous procedure that is office-based, the patient is awake, and the vein is not quite what we thought was going to be, because the report was wrong, or because the vein was mistakenly confused with another vessel, and then you cannot perform the ablation because, let's say, it's less than 1 centimeter from the skin, and obviously the risk of skin injury is higher. So what are you going to do? What are you going to say with the patient awake there? That is what I think is so important, that the physician is familiar with the ultrasound, the equipment itself, but also the interpretation, because at the end, you are the one, you vascular surgeons or phlebologists are the ones going to be doing the procedure. Take a quick scan of the greater esophageal vein or lesser esophageal vein. Takes 10-15 seconds just to see the anatomy. Once you have enough experience, it's enough to see the depth, the diameter, more or less gauge, and plan the point of entrance, etc. So again, we are going to start with some of the basics of ultrasound. One of my teachers here at Methodist, almost 20 years ago, Dr. George Soltis, told me, ultrasound is like air conditioning. Once you experience it, you can't live without it. And it's true, because it's a handheld eye, extra eye. That third eye that some cultures said we have here, well, I think it's here because you can see clearly through the body in certain areas and have a better idea what is afflicting our patients and how can we help them. So again, the story is, what everybody makes of it. If you go back until 1794 with the Italian biologist Lazzaro Spallanzani, that was the first one to describe echolocation in bats. That was the first understanding of the sound and the reflective surfaces, and therefore all the technology that follow after he described that. And you can see a summary. There is a lot of other events that happen in order to develop the ultrasound, the machinery, the equipment that we have today. And we went from big machines that is described in this paper by Goldberg in 1993. Obviously, this is an archive picture. This is not from 1993, in which the machines were huge, and also require a tub for the patient to get in there, in the tub, in order to have some good penetration with the sound waves and obtain a decent image, right? Now, all this has evolved to, and again, we are not endorsing any products in this program. This is what is in the internet, and I don't know if it's projecting in your computers or not, but at the end I put all the references. We are not endorsing anybody. But the ultrasounds that we have today are just one single piece handheld that connect to your cell phone. So the technology has evolved immensely, and has improved also the picture that we obtained, like this leg back in the early days. This is a picture of a thigh, I believe, that was obtained with one of those huge machines to clear pictures that help us diagnose the patient, or miracles like this. So this is what the ultrasound has provide for us. But how does this work? And again, I'm not going to go into details. This is not a physics class, neither I know that, but I think there are some basic concepts that we need to manage as a physician in regard of the ultrasound. The first is the units, the hertz. And the hertz are just what events per minute. Any given time unit, second, hour, days, whatever it is, how many times that event occurs in any given period of time. So when we have 1,000 times, it's a kilohertz, megahertz, and gigahertz according to the events per second. And this is standard unit that we manage in ultrasound. Now the human ear is able to capture sound between 20 hertz and 20 kilohertz. So below that is infrasound, above that is ultrasound. So all this technology is going to be based above 20 kilohertz. So the medical ultrasound is 1 and 20 megahertz. And this is the first hurdle that I want you to pay attention. If you ever take the test to be RVT and be certified as a registered vascular technologist, you need to know the units, because it's where they get you. You say, well, you just said that ultrasound is above 20 kilohertz, so how is medical above 1? Well, it's different unit. Is megahertz, and that equals to that amount. So we need to be careful when we use hertz, kilohertz, megahertz, especially taking the test, because it's not fun when your calculation doesn't come as you expected. So the sound is a mechanical energy that is composed of compressions and rarefactions. That means pressure and release of whatever medium the sound is traveling. 99% is through the air, so the sound cannot travel in the vacuum. So that's something that my daughter taught me in regards of science fiction. When you see all those movies that you hear explosion in the space, there is no such thing. There is no air, there is no sound. So, but it's important to remember that, because the medium with the media in which the sound is going to travel is going to influence how far it's going to reach the depth or whatever area we want to explore. I'm being interrupted just for 1 minute by my floor manager here, because I forgot to mention, of course I forgot, that if you have any questions, please, they are going to put the data in the screen. Please, if you have any questions, any comments during the broadcast of this show, contact us, and we'll pull these questions and try to answer to the best of our abilities. Once this housekeeping is taken care of, let's go back to the business at hand. So they cannot travel in vacuum, and all depends on the mediums that are traveling is gonna influence the image that we are gonna get in the machine. So when you combine sound and image, it's two different things. 1 + 1 is 2, duplex. Duplex ultrasound is when you have image and sound. So the basic way in which the sound travels is waves, as we know. And we are going to imagine we have an even wave, because again, we are going to make this simple. It's going to have different areas. The period is when 2 points at the same level occurs and completes a complete, I'm sorry about the redundance there, completes a cycle, a curve when it comes back to the same point that will start. That's a period, and that's in relation to time. Now, the wavelength is in relation to distance. It can be confusing because you can put, the wavelength in this slide, for example, is at 2 similar points, and that can be a period, correct? But it's not about time, it's about the distance. So period is about time, wavelength is about distance. This is the amplitude of the wave, and of course there are 2 areas of the wave that you need to know, the crest and the throat. So, and the frequency is how often you get that in a period of time. It's not how long does it take, that's the period, but how many events happen in a period of time. Those are hertz, we talk about it, and that's the frequency. So the ultrasound, the sound has different acoustic parameters. There's a period that we saw is about time, frequency is about quantity, wavelength is about size, speed is about meters per second. Now, speed is not quite in relation to the sound itself. That's the medium in which it's traveling. It's not the same air, that water, that bone, that cement, etc. So that's going to be meters per second. Now, the other three are amplitude, that is going to measure in decibels, power in watts, and the intensity, that is going to be a combination, is watts per over a square centimeter. Now, from these acoustic parameters, and we'll see the use of this in a minute, in a very simple way, I hope, the ones that can be changed by the sonographer cannot be changed by the sonographer are the first four. They are intrinsic. That means the period you cannot change, neither the frequency. The only way you can change that is by choosing a different probe in the ultrasound machine to begin with, as well as the wavelength size. And the speed also, you cannot change the way the muscle is made and molecularly as opposed to water, as opposed to air. So you cannot change those. What you can change are the amplitude, the power, and the intensity. And that's the controls that we have in the ultrasound that are going to allow us to get the best possible image, so we have a better idea of how to help our patients. So if we have this leg, and I'm sorry, I want to take a sip of water here. If we have this leg here, and we take this skin out, now this is not anatomically correct, okay? We can see the leg there with the muscles, the bone, the venous system, and some rather, like my mentor, Dr. Lumsden, might say, a little bit ratty artery there, craggy artery with some disease. So if we do a close-up of this, and let's say that we use a ultrasound that is between 3 and 12 megahertz. This is a high-speed ultrasound. It's going to penetrate to a certain level because the frequency in which the wave is produced is more often, is closer to each other, so it's going to rebound faster and it's going to give us information from a shallow area, not a deep area. And this is when we use for vascular ultrasound, that we need to see something superficial, etc. So, but doesn't mean that you cannot see deeper. This is an example of, this kind of ultrasound in which we see is about 3 centimeters in depth. We can see that in the slide, and it's a clear image. And if you get the Doppler and the computerized conversion to color, you can see the colors on the right side of the screen. And this image represents that. But what I was mentioning is that the waves, they don't bounce like that. And as a matter of fact, the waves keep going down. Doesn't mean you don't see the tissues deeper than what you are intended. You do, but they are in very, very bad quality because the medium, that is the muscle, the bone, the skin, whatever, is attenuating the intensity of the energies, it's absorbing the energy of this wave, and then the image is not as clear. So that is important to know, and we can see this. We can put the same ultrasound that we had before, and we put it at 7 centimeters, and you can see beyond the blood vessels. Really is blurry. You don't have a good image. You don't know what is in there. There are also some echoes. You can see there the artery on the right side where the color red is present, and then on the left, without the color, you can see there is an image below the artery that simulates a reflection. That's an echo. That's an artifact, because the images are not good, because producing some interference with itself as the wave rebounds and goes back into the probe. Now, if we choose a probe with less frequency, less amount of waves, what is going to happen is going to have more space between the waves, and is going to allow us to see deeper with more clarity the images that we are looking for, and we can see this. Now, you notice, maybe you don't, but you notice that the depth of this ultrasound is 5 centimeters. The other one was 3 centimeters. I wanted to put two pictures equally, 3 centimeters equal, but this probe in its own design in the machine we have in our office doesn't let you go below 3 centimeters because the image is going to be of low quality. So the minimum you can go is 5 centimeters and higher. So what happened when you let this go further, then you are going to have a better reflection and a better image. And then at 8 centimeters, you have a very clear picture of what's going on, in this case, in abdomen. And these pictures were taken by my absolutely fabulous vascular tech, Mrs. Heather Costello. She is an expert doing this, my studies in my office. And as you can see here, the two comparisons with, you go to 8 centimeter with a low frequency probe versus a high frequency probe, 7 centimeters, 8 centimeters, and you can see the difference. So choosing the right probe, the right instrument is going to be key for you to obtain that image. Now, as I mentioned, the higher the frequency, 3 to 12 megahertz is the vascular probe, the flat that everybody knows, has better resolution, greater the tissue attenuation, but less penetration. That means you can see better immediately right after the wave is bouncing. The lower the frequency is the other way, and the probe that we use for deeper tissues, abdomen, etc., is 5 to 1 megahertz, at least in the machine we have in our office. That is a Philips. So the other part that I like to talk, and it's not about this, don't panic, because I don't even know what that means, is the Doppler effect. In as simple way, as we know, the easiest way to understand this is when some object, a car that everybody puts as an example, moves, it's going to compress the air that is going ahead of it and then dissipate the air behind. If you add sound to that, it's going to have the Doppler effect that we are familiar with an ambulance is coming towards us and then goes away. The sound is different. That is what we use in the blood vessels to see the velocity and the direction in which the blood flow is going. And then the machine itself is going to give a color, an artificial color, and that's why we see red or blue. It's not because it's red or blue. As we can see here, it travels in the same way, the bloodstream travels in the same way, and is dissipating the energy at the tip of the initial laminar flow, and that is what is going to give the Doppler effect that will allow us to give this a amount of velocity or color, etc. And the perfect angle is 60 degrees angle. That's what the equation says. So the ultrasound, as what I just mentioned, is going to assign the color artificially, and we can see here when these images, with or without color, according to the Doppler effect that is capturing from the vessel in question. All these details are important that we know about this, because again, we are going to be making a decision to take care of a patient or not, or how, and not just going blindly in whatever the reports say or do, because it might not be what you are thinking. 99% of the time it is, but the last thing you want, in my opinion, is having your patient there and then you can't do the ablation because it's not anatomically adequate to do the ablation. Of course, I mentioned earlier about that is less than a centimeter. You are not going to do it because you are going to burn the vein. Of course, somebody is going to say, well, you can inject it to tumescent and push the vein down and you get a centimeter. Yeah, absolutely. And what is going to happen to that tumescent? It's going to be reabsorbed. The vein is going to go back to its place, and then you are going to have a nice, beautiful hemosiderin strip along the inside of the leg that the patients love that much. So no, we need to be careful, and I'm a heavy proponent of that. The doctor needs to do a quick scan before proceeding with the whatever surgery he or she is going to do. So these are the basics of the ultrasound that I wanted to talk to you. Of course, there is way much more, but just to hopefully pique your curiosity so you can read more about this and understand why we hold a machine and look into that. And another analogy that I'm thinking is when you prescribe a medication, you are bound to know at least the basic pharmacodynamic and kinetics of the drug you are prescribing. You are prescribing a medicine to a patient. Well, if you're grabbing an ultrasound, at least know how the basic of that machine is, so in order to understand what you're looking at. So that is the first part of this presentation of today's show. As I mentioned earlier, I'm extremely happy and honored to have our guest today is Dr. William Marston, professor of surgery in the University of North Carolina, Chapel Hill. He's a great friend of ours, and he's going to be presenting their experience in regard of ultrasound assessment, evaluation, and they have a great amount of experience in this field, and I'm excited that he decided to join us. Welcome, Bill.
Oh, it's a pleasure to be here. Let me go ahead and share my screen with you. All right, are you seeing that up?
Yes, yeah, it's nice and clear.
Great. And let me just tell you a little bit about myself. I am a vascular surgeon at University of North Carolina. I trained here, actually did both my general surgery and residency and fellowship in vascular at UNC, and have been there now for almost 25 years on the faculty. And one of the things that I got interested in after I got tired of doing the aneurysms and carotids was wound healing and people with critical limb ischemia. We started a wound healing limb preservation center about 20 years ago, and it's really just been tremendously successful because of the high number of people in states like North Carolina and Texas with diabetes and bad vascular disease who really need a place to go that can manage these problems. So along with this, you also get a ton of patients with venous disease and ulcerations, and they tend to have complex venous disease. And so that's really where my experience comes from. We've done a lot of clinical studies and trials in this arena over the years. But I would start first by just complimenting Dr. Baltazar. It's incredibly difficult to talk about the physics of ultrasound and the basics, and he did just a great job with that. But one thing I'm totally going to agree with on is that it's really important if you're going to do procedures and diagnostics and manage patients that you have an understanding of ultrasound and you're able to do it yourself. We have excellent technologists at UNC, and I depend on them tremendously, but I also always do a quick ultrasound myself before doing a procedure. And sometimes they're just too busy to do all the ultrasound I'd like them to do, so you need to be able to work with it yourself. So I'd like to really take the clinical side of this and talk about patients and what I'm trying to understand and how ultrasound helps me. So standard common type of patient we see over and over in our vein clinic is a 52-year-old female, had a long history of left leg swelling and varicose veins, kind of runs in her family. Symptoms seem to be slowly getting worse, legs getting more heavy and painful when she's standing. And you look at the leg and you see a prominent saphenous vein and typical medial leg varicosities. Got some hyperpigmentation, a little bit of thickening down in the gator region on the medial side, and swelling, but no ulceration or things like that. So this would be a patient who might be a CAP clinical class 4A, and they're very common. And so the question is, what do we need to know to treat this patient? Then here's a second patient, a little different, but also complex venous disease, a 52-year-old male had multiple DVTs starting about 11 years before we saw the patient, history of protein C deficiency, bilateral edema worse on the left. And here's the ulcer that you can see on the medial aspect of the midcalf. And he's really having a lot of trouble. He can't work. He's got a lot of discomfort and swelling, and he's really got a pretty low quality of life right now. So when you start to look at that again, what is the information you need to treat this patient? You don't know that this is venous disease. It could be other things. There's clearly other things that cause ulcers like this. With his history, sure sounds like venous disease, but how are you going to make that diagnosis and then start to treat the patient? So when I think about venous disease, the first thing I'm thinking about is that the symptoms really are due to abnormal inflammation in the tissue. That's usually when they get pain, they get discomfort, aching, heaviness. So I'm trying to determine what is causing this inflammation. And if it is truly venous disease, it's venous hypertension, because you get dysfunction in the venous system. That causes hypertension. The pressure should be low in the venous system. And when it gets elevated, that then causes inflammation. And it may be a pretty mild symptom day to day, but over years of time, this small amount of inflammation will build up and start to cause tissue damage. And that's where patients start to get to, hyperpigmentation, some lipodermatosclerosis, and then eventually they can ulcerate. So it's this chronic process that really is this tissue inflammation that leads to their symptoms. And so the key to treating patients that have venous disease is identifying the source of their venous hypertension and either eliminating it with a procedure that's going to correct the venous problem or controlling it with things like compression therapy. So if you talk about in the venous system, why do they get hypertension? It's two buckets. It's basically reflux or it's obstruction. So if the valves don't work properly, if they don't close properly to prevent reflux of the blood down towards the foot, then the orderly process of blood moving back up to the heart is short-circuited and the patient gets hypertension down towards the ankle. This can be congenital or acquired, and that's usually the case in the superficial system, or it could be post-thrombotic, and that's most often the case in the deep venous system with after DVT. So the other bucket of things that occur is obstruction, not related to reverse flow, but the blood cannot get out of the leg due to blockage of venous segments. And this could be compression related, so it's not intrinsic to the vein, it's compression externally, such as May-Thurner syndrome, where the iliac artery compresses the iliac vein. There are all kinds of compression spots that can occur. The inguinal ligament can compress, the hypogastric artery. So these are things that will cause distal venous hypertension. Or patients can have narrowing of the veins from post-thrombotic condition where venous thrombosis causes thickening and shrinkage of the vein that results in compression. So either of these mechanisms will cause venous hypertension. That's what we're looking for when we're looking at our venous ultrasound studies. So I'm thinking when I'm looking at the patient first, is this actually venous disease that's causing their symptoms? We see lots of patients where the venous exam is normal, but their leg kind of looks like it's a venous etiology, but we find that it's truly not, and it may be lymphedema, it may be a variety of other conditions that are causing the symptoms. If there is venous insufficiency, where is the abnormality? What's the anatomic location? And how bad is it? You can have a little bit of reflux, you can have a lot of reflux. And we'll talk about how you identify those differences. Duplex scanning is really good to define the anatomic sites of reflux in the deep perforator or superficial system. And it's also good within the leg to identify venous obstruction. It's not quite as good in the pelvis because you can have obstruction or difficulty due to bowel gas, although really skilled technologists can get very good examinations of the iliac veins and vena cava. It can be limited in some patients. So here's our protocol. We do both a supine and a standing study, and the supine position is very good for looking at sort of mapping the entire venous system, looking for anatomic variability, which is frequent in the venous system, more often than in the arterial for sure. we're looking for signs of previous DVT or superficial thrombophlebitis, where you would see obstruction or thickening of the veins. We're looking for incompetent perforators, but you cannot really evaluate the patient for abnormal reflux in the supine position. You really want to put that vein in the upright position where it has to close to get a good idea of its function. Now, one aside is this technologist here is my man Dustin. He's really an outstanding venous technologist. And so you got to talk to them and let them know what you're looking for. If you just send a patient to a lab and read a study, you're not going to get nearly as much information as if you really know the people that are doing these studies for you and review the findings, particularly interesting things, with them. They really love to talk about interesting things that they find. And so it's really important to get a relationship with them. Also helps you be a lot more confident in what they're telling you if you really know them. And then the other thing, as Dr. Baltazar said, is to look at the actual tracings and the images themselves, not just a report. And this is important because you want to really consider the hemodynamic importance of the duplex findings. So you may have reflux, and it may be a little bit or it may be a lot. And that what really matters is how much is the blood moving in the wrong direction, i.e., what is the likelihood that this, you may find some reflux in one part of a saphenous vein. Is that venous abnormality causing the symptoms, or is it an innocent bystander? We did a study back when I was a resident where we captured all of the residents in the hospital, or at least a bunch of them, and we studied them for venous reflux at the end of the day around 5, 6 p.m. And about 20% had abnormal reflux in the saphenous veins, and they were essentially asymptomatic, or at least they weren't complaining about any symptoms. So you want to really think about if you're actually finding the cause and if the thing you're seeing is causing your symptoms. And is the venous abnormality you're looking at a source of significant venous hypertension? So the other thing to think about is that there's a lot of focus on the time of reflux in a vein. And I think that's primarily because it's required in order to get insurance approval to do venous procedures. But reflux time is only one determinant of the amount of venous hypertension an area might cause. So you want to think about the size of the vein you're scanning, the reflux velocity. So is it high velocity or not high velocity, as well as the time? And that actually allows you to determine the reverse flow. What is the amount of abnormal flow in that vein? And I'll show you some more information on that. If you've got reflux in a great saphenous vein and you've got a patient like the first one I showed you who has symptoms and you're scanning it, the normal saphenous vein in the thigh should be 4 or 5 millimeters. So if you're scanning a vein and you see maybe some reflux, but the vein is really not any bigger than the normal saphenous vein, I would really wonder if that's the source of any symptoms. Most of the patients that I see that we intervene on, if they're small, some of them do improve. It's not that you can't do the study, but you have a higher chance that you do that ablation, the patient's just not going to have any improvement in their symptoms. So you really want to be able to counsel the patient and say, look, you've got some reflux here, but your vein really isn't enlarged. I'm not sure this is going to improve your symptoms if we do this procedure. So at least they're aware, that you're not telling them this is definitely going to improve their symptoms, and they may choose another form of therapy. Now, one other thing that you can look for in the supine position is what I call the enigmatic perforator. So perforator veins communicate the deep and superficial system. And here's the tibial vein, and here's the saphenous here, or a branch of the saphenous, and a big perforator going through the fascia. And these are seen often in patients who have venous ulcers or other complex disease. And what they tend to do is when you have deep venous hypertension, the perforator valve gets blown out and it allows flow to go up to the skin and then be part of causing a perforator. And you evaluate these with the patient's supine position by compressing and releasing below the perforator to see if there's reverse flow. Flow should all go inward If it goes out, then you've got an abnormal perforator. But we don't really have a great handle on exactly what is an incompetent perforator that's causing problems. So there's not great studies to say, perforators of this size, when we corrected them, patients got better versus not. And there's general agreement that the perforator that is really pathologic is one that's greater than 3.5 or 4 millimeters in diameter and allows outward flow for greater than a half a second. And that's generally the criteria we use, but it's not one of those that's been validated by really good studies. So the way I look at it is, again, I want to see a big perforator, large size, and I want to see one like this where you see in a whole lot of reverse flow when you do your compression and release versus one that just has a little bit of reverse flow here in column B. And so you can see the difference between A and B. Now, both of those would meet criteria for an abnormal perforator. They both reflux for more than half a second. But A is bigger, has higher velocity of reflux, and refluxes for a longer time. So it's probably causing more hemodynamic impact than the perforator over here in image B. So then we move to the standing component of the reflux of the scan, and that's where we test the valves for their closure and whether there's abnormal reflux or not. And we use a cuff on the leg below the point that automatically inflates and deflates quickly. You can also use your hand to squeeze the leg and do it that way. And actually, a study that Fedor Lurie led showed that there really wasn't much difference between these two methods. But it is easier on the technologist if they can have one hand to operate the ultrasound, another for the scan head, and not have to use a third hand to squeeze the leg. So we use this position and examine all the different valve segments for abnormal reflux. And this is what a normal tracing looks like here, where you see flow forward with compression, and at the point of release, just a little tiny blip of reverse flow. Nothing after about a half a second is considered to be normal. Compared to this abnormal tracing with release, you have a long, prolonged amount of reflux. And this one is pretty high velocity in this situation. So this is the type of report that you might get from a lab. And it has the different segments they examined and the reflux duration. And particularly for the saphenous veins, they're going to tell you, they should tell you the diameter of the saphenous at those locations. So this patient has reflux, which is defined as normal is less than half a second. So the deep system is all normal, as is the small saphenous vein. And the great saphenous is refluxing throughout its length, and it's pretty big, 8 millimeters and 6.5. So that patient would be a good candidate for a procedure to eliminate that saphenous vein. We used to strip them, which was a lot of fun for us, but not so much for the patient. In fact, the medical student used to be the one that, pulled the ripcord to get the vein out. But now we use laser or other thermal ablation techniques, or now glue or sclerosants to do the job and leave the vein in place, just close it down. This is a different patient, more like the second patient we mentioned, and this patient has reflux in the deep and superficial systems, and this is pretty common in patients with ulcers and more complex venous disease. So that patient, you've got to decide what you're going to do. We don't have good therapies to treat patients who have deep venous reflux. Right now, we don't have a really good surgical technique to repair the valves, and we don't have any real percutaneous techniques to replace or repair valves in the deep venous system. So this brings up a bit of a conundrum. Again, now, I would emphasize, always go and look at your tracings. And so here's a popliteal vein reflux tracing on the top, and you see, you've got your compression and then the release, you've got reflux that goes on. But if you look at your velocity over here, this is meters per second, you're at about 10 centimeters per second or less. So it's sort of just a little slow bit of reflux there compared to the tracing on the bottom that has really high velocity reflux through that time. So there's something that's different about those two situations. And it's important because you're going to see multi-system reflux a lot in patients with venous disease. In our study, it was about 27%, and Nikos Labropoulos, about 22% of patients have both saphenous and deep system reflux. So we think that if the velocity of this reflux is less than about 10 centimeters per second, it probably doesn't matter much in the deep system. You can go ahead and treat the superficial disease like you normally would even if the deep system is totally normal. And we actually published information on this in 2008, where we studied 75 patients with combined deep and superficial disease. And the question is, can you go ahead and do a laser ablation or any type of ablation of the saphenous vein when you have this deep system reflux? And our finding was basically if it was low velocity reflux, they had better improvement after saphenous ablation than if they had high velocity reflux in the deep system. Excuse me. And again, it doesn't mean that you can't do the superficial vein ablation if you have high velocity reflux, but you just want to counsel the patient that they have this other problem in their deep system. You're not going to correct that. And they may still have symptoms despite going through this procedure. So they understand what to be aware of and the reasons that you're proceeding with the procedure. You look a lot smarter if you tell them about these things ahead of time than if you go back afterwards and they wonder why their symptoms didn't improve. Here's another thing I think you got to be really careful about, and this comes when you're evaluating patients who had studies done at other vascular labs. So this is a patient I saw who had vein ablation done for pain in the leg, and their pain did not improve. So the patient came to me for a second opinion, and I asked for the pre-procedure tracings, and what I saw was this. There is reflux here, but if you look at their scale, they've got the gain turned up so high that this is about 2 centimeters per second of velocity of reflux, which is essentially noise. So I would not have said that this patient had abnormal reflux. So this probably was a needless procedure that they went through. And this is not uncommon, unfortunately, out in the real world. This is a more typical patient who has, 30, 40 centimeter per second of reflux. And that's a patient who I think is going to, has a problem. This is likely the cause of it. It's causing a lot of venous hypertension. They're highly likely to improve if you perform a procedure to close this vein. So if you sum these things up, and I was asked actually at the VEITH conference a few years ago to say, can you predict venous severity based on reflux time? And so my answer was really not by itself. You've got to also put in there reflux velocity and the size of the vein, and it's all about the flow. Like you wouldn't go to a fire with a garden hose to put it out. You need a big, hose with a lot of flow. And so, go through all these steps to figure out what you're seeing on your ultrasound and whether it's causing the patient's problems. And the last little bit I'm going to talk about is the compression syndromes and iliac obstruction and how we look for that with ultrasound. So this is a picture of the May-Thurner compression, right iliac artery compressing the left iliac vein against the spine, and that causes downward venous hypertension. So when we do our ultrasounds, we are very careful to look at the common femoral vein below that. And the normal common femoral vein tracing has variability with respiratory inspiration and expiration. You see differences. And if you squeeze the leg, you can augment the flow. And so that's a normal tracing. Down below, we see a tracing in a patient with outflow obstruction, whether it's intrinsic or extrinsic, and they don't have variability with respiration. It's a static signal, and even with augmentation, they don't change much. So that's highly suggestive that there is outflow obstruction in the iliac veins or vena cava. This is a specific finding that's not all that sensitive. You can have narrowing of the iliac veins, generally fairly moderate. But if you see this, you almost always have significant obstruction of the outflow. And Like I said, the sensitivity isn't that good. So if you have a normal tracing, but you still really are suspicious, you should go on and get another study, such as a CT-MR venogram or actual venography with IVUS if you're highly suspicious. So just back to a case before I finish. This is a 57-year-old female, and you look at a leg like this, and you can almost say, even before you talk to them, they've had ulcers for decades. The skin is just terribly scarred. All that hyperpigmentation, that sclerosis, it's going to be a very difficult wound to heal, very slow healing, unless you excised all that tissue, which plastic surgeons generally don't want to do. This current ulcer had been present for 9 months and really wasn't improving much with bandages. So this was her diagnostic study, and she had reflux again in the deep and superficial system, pretty high velocity reflux in the popliteal, and she had a static waveform in her common femoral vein. So how would you treat this patient? You've got deep superficial reflux, both of them probably pretty high velocity, and you've got outflow obstruction. So would you go ahead and evaluate the iliac vein for obstruction and stent it if it's high grade? Would you do a saphenous vein ablation? Would you do 1 and 2? Would you try a procedure to create a new deep venous valve? So what we did is we did 1 and 2. So we found that the iliac was about 85% stenosed based on our IVUS measurements. So we inserted a stent, and we did perform a laser ablation of the great saphenous vein and injected local varicose veins around the wound. It's generally our concept that these patients need pretty much everything done that you can with a bad ulcer like this. And our repeat studies, we always study our patients within a month of a venous procedure to see how the anatomy has changed. And we found persistent deep venous reflux, but the saphenous was closed and the iliac was open. And we had improvement of about 70% 3 months later. And the patient, it took probably almost a year to fully heal. Still very slow, but eventually healed. Of course, she came back a couple of years later with another wound, but that's what they do. So just to briefly summarize, venous duplex evaluation with ultrasound is really the key diagnostic for venous disease. It provides good information of a variety of methods that I've gone over, and really, again, learn to use this yourself, not just for venous disease, but any vascular disease. It's a great tool for all aspects of what we do. Thank you very much. It's been a real pleasure to speak with you, and I'd be happy to listen to some questions.
Thank you so much, Bill. This was a phenomenal presentation. I mean, very informative. You covered exactly what I was yearning to put on today's program. So I have a question for you. When you have a patient that you are questioning if the ablation is going to help, one of those borderlines, I have a saying that the devil lives in the gray. When it's black or white, you know what to do. When it's in the gray, you don't know what to do. So when you have one of those patients that maybe is 5 millimeters in diameter, the greater saphenous vein, the reflux is just over 500 milliseconds, the velocity might be increased, but you don't know if you will help him with the procedure. Do you have any specific tricks for that particular patient?
Yeah, my belief with all venous patients is understanding what their goals are.
Yeah.
So, if it's a patient who's there because they have varicose veins and it's, there are some symptoms, but it's also cosmetic, they're going to want you to treat it to get rid of the veins anyway.
Yes.
And so I would just make sure you talk to them and say, hey, I'm not sure if this saphenous is the problem for sure. There's something wrong with it. We can treat that. We can also, address your varicose veins, whatever technique you like. But making sure they understand what you know and what you think the likely outcomes are is critical. If you just go in and say, oh yeah, we'll do this, it'll take care of it, and then it doesn't quite go that way, then they're really suspicious of you after that.
Absolutely. Now, regarding the angulation in which you do the reflux study, I agree with you. As a matter of fact, when the patients come back to the room so I can talk to them, I do the scanning that I mentioned earlier standing. Nobody is in the bed. Right. Now, is your ultrasound technologist putting in certain angle that you recommend for our viewers? Any specific, or just as much as the bed allows it, or how does that work in your place?
Yeah, it just has to be, by the parameters less than 60 degrees, to get a decent tracing. But, and they're so good at doing that they almost never come and ask me to, help them with that. The things that they ask me about always are anatomic variability. The small saphenous doesn't join the popliteal. There's, an unusual connection to the deep vein up in the thigh. Those are always the interesting things, and you find them all the time.
Correct. Yeah. So the patient, very interesting conundrum there with the patient with all the diseases, basically, obstruction, reflux, hypertension, and an ulcer. So, I don't know if you remember one of the research tests in the vascular boards, of course, the patient didn't have obstruction, iliac obstruction, but the answer was compression. They want compression on the board. So, compression is the key. But I agree with you. If you have an obstruction, it's going to be a devil to heal that ulceration.
They don't respond to compression. You actually, they're the ones that the nurses brand them non-compliant because they take their wraps off, and because it's painful to have the compression wrap on when you have outflow obstruction.
Of course, absolutely. Lastly, because we are running out of time, but what do you think about, the perforators are iffy, right? You mentioned it. Sometimes there is not really a protocol or randomized trial that said, this is the diameter, this is the velocity, period. There is no such thing. But what I follow, I don't know what you think about this, is when you have a perforator, obviously more than 3.5 millimeters or 4, that is right under the ulcer. Right, with something that is causing trouble.
I completely agree with you. And so we did a study. This is Bobby Mendez, one of my former partners, published. And patients who had saphenous, reflux, and perforators, if you just got rid of the saphenous, 80% of the perforators no longer had abnormal reflux. So we tend to do the superficial first, but exactly the situation you mentioned, if they still have reflux in the perforator and they still have symptoms like an ulcer that won't heal, or that sometimes they get just this sort of red, painful patch where the perforator is, then I would go in and take care of it. I don't know what you like to do, but I like doing it with the laser, just like spot weld it.
Laser is good. I like it. You mentioned about your residents when you were a fellow that you were capturing the residents to do the study. I was thinking about it because some patients come to me and they are tellers, teachers, doctors, colleagues, and we stand 2 or 3 hours doing a procedure or whatever, and they complain of leg edema, leg pain. I check out the greater saphenous, is 3 millimeters, there is no, etc. So what I tell them is, the thing is, we are not designed to be standing still. We are not. The whole calf pump works by walking. So I was wondering, of those 20% that you documented with reflux, if that reflux was present the day after they rested. That'll be interesting to see.
Yeah, we didn't study it, but you're probably right. And I guess this is where, a lot of these places are doing I had a patient I saw on Monday told me about his treadmill that he has at his desk. So he's walking while he's doing computer stuff and whatever. So that's the purpose of that.
Well, I think we are close to finishing here. Dr. William Marston, we are very honored that you help us today, and this is a forum open to you as well. Anytime you want to come and visit us, you are more than welcome. Thank you very much for your insightful presentation. And I hope I see you soon in one of the meetings as soon as we are back out there.
Yes, hopefully soon, yes.
All right. Thank you so much, Bill. I appreciate it.
You're welcome. You take care.
You too. Thank you. And this is all for today's show. We appreciate you tuning in. And I'm not going to froze like last time. It was my first time on live broadcasting, so I froze. I didn't know. They were telling me cut it, not cutting. I didn't know. This time I have time to say thank you so much for your attention, and I will see you next month. We will have a show on the Wednesday before Thanksgiving Day. We'll have some good guests and good topics for you. Thank you so much, and God bless.